I wanted to make just 3 quick announcements, if you don't mind,
Please.
before I briefly introduce you. Um, 3 things. Number 1, um, there's a mentorship panel that's part of the American Academy of Hospice and Palliative Medicine's Neuro-Palliative Care SIG. And it's going to be focused on careers caring for people with ALS. I have no idea why my thumb is going up, but sorry about that. And it is on Wednesday, November 19th at, hang on a second, I think it's noon Pacific. Yeah, noon to 1 p.m. Pacific, which is obviously later if you're in other time zones. And it's by Zoom. You can register through the AHPM Connect platform. So if you or trainees you work with or other members of your team might be interested in hearing from a range of folks who work caring for people with ALS, either in a palliative care capacity or on the ALS team, we'll be hearing from such people, including Umbreen and maybe some others who've joined this call, like Nuna and Farah and Jessica Besbris, as well as a social worker I work with, Greg Merrill. So it should be great if we can spread the word.
I think, correct me if I'm wrong, but I think you have to be a member of the AAHPM to be able to register. So if you're not a member, but if you have learners who are interested in becoming members, it's kind of a nice opportunity for them to do that. And they usually have a pretty fair discounted rate for membership, and they can turn around pretty fast. So just be aware that it's membership only.
Yeah, true.
And this is just for clinical.
It's for clinicians interested in a career in this area. And then number 2, we are moving forward with building this directory of outpatient palliative care programs that have an expertise in caring for people with ALS. And if you haven't yet entered information about your program and you are an outpatient palliative care program that has an interest or experience caring for people with ALS, we would love to know about your program. Or if you'd like to enter information about another program that you know of or nudge someone to do so, that'd be great. I will put in the chat the link to that very brief survey and enter information about your program. If you don't remember if you completed it or not, feel free to reach out to Gail during this call and we can clarify whether you're in there or not. We'd love for it to be as complete as possible, and it's going to be updated on an annual basis to kind of keep it current. And then number 3, we, along with this international team based out of Sydney, Australia, we are moving forward with this project, sort of QI project, to try to understand how clinicians are managing sialorrhea in people with ALS. And the survey is out of its pilot phase and now live. And we would love for any of you who see patients with ALS and sialorrhea to enter information about specific patients with in that situation and how you choose to manage their sialorrhea and what outcomes result. But you will likely need IRB approval from your institution, and we would be very happy to try to help you through your IRB application. We did get IRB approval at UCSF and we're entering data now. And we'd love to help other institutions around the US participate in this international project. And we're also actively building some surveys about the management of other symptoms in ALS. So we, again, can understand how clinicians are managing various symptoms in ALS and how well those treatments are working, whether any side effects are developing. So if that interests you, please let me know. We'd love to get you involved in this whole series of projects. Sounds good? Any questions about those 3 points? I'll be here in the chat if you want to write to me, or we can talk offline. And then without wasting any more of Joe and Judith's time, I'll say thank you. Joe Green, a board certified chaplain, and Judith Mintz, LCSW. They are from Unity Hospice. They've done a lot of work around caring for people with ALS and have developed this ALS Values Assessment guide that they're going to talk to us about today. So thank you so much for joining us. This was a connection that Benzie helped to make, and we're just delighted to have you as part of our group now. So I'll hand it over to you.
Well, I appreciate that. Yes, Judy and I have worked together. We're in our 16th year, and we have a great relationship with now what is ALS United here in the Chicago area and some of our outlier offices. And we have learned a lot formally, but also just by our experience. And a lot of that has driven what we have here to show you. We've vetted it in a number from social work. We were, but really, it broke a lot of ground. We presented at the International Alliance Conference in Basel 2 years ago, and then last year met Mariband in Montreal. I mean, I thought, and she agreed that a lot of what we're doing dovetailed with her presentation. Actually, it was George Fitchett. We presented at the Association of Professional Chaplains Conference earlier this year, and he connected us to Dr. Kluger, and here we are. So we appreciate the opportunity. We'll do a brief walk through the guide. I mean, I know for you all it doesn't need a lot of background and explanation, but understanding that this is a working group, we would like to get your perspective. I mean, first your impressions, the value you see, and the usefulness of this guide. We'd like to see more opportunities for it to be vetted, even researched, possibly. I'm not a researcher. I'm a research literate chaplain, as George likes to say, but would be interested in that. Even the conference for the organization, I don't know if this is along the line of what they are looking for there in a broader audience, but just to increase the use of it. I've never felt like it was had taken on what we'll express as the value we see, and that many have recognized. So with that said, I just want to do a little bit of an introduction here, and then Judy can kind of walk us through the primary aspects of the guide. And then before we get away, if we have time, she and I have had an interest in and done some seminal investigation with our patients on sudden death events in ALS and preparedness for that. So if we get an opportunity, I'll share a little bit more about that. So the basic idea here, this is a goals of care planning guide, but really to emphasize information and to help people know try to find out what they don't know. They don't know what they don't know, and it's really effective with a clinician, or for individuals it can be microdosed or done once. But basically the concept came from the idea that we would see the trajectory of the disease, and people would express goals of care and outcomes. And so we would file back and saying that here's the decisions we need to make now so that those goals can be met. And so it was immediately recognized as somewhat unique among all the resources. It's a gateway. It's not exhaustive, but we think it is comprehensive as far as opening the conversation and giving people a workbook. Now, I'm showing it to you here from our website. It's also on your ALS Guide website. We have a printed, wonderfully, I don't know if my camera's showing me or not, but it's a very well done hard copy that we use in our company. We use it for education, for care plan meetings. Judy and I do a monthly consult we have 7 offices in 5 states, and we consult on ALS. And it's a lot driven from the psychosocial perspective, as you'll see. And there was a number of us from different disciplines that represented it. Testimonials there. And so I'm kind of jumping around here. Yeah. I mean, here's the layout of the guide and where we're headed. We've identified 9 areas of that you need to talk about. What if and what then is the primary theme, and we believe it helps people and gives them hope. I mean, people typically want information, I think, and we found that a lot of what we would offer them is in medical care is reactionary, and we thought it was important to make it anticipatory, and to equip our clinical team as highly qualified as our staff is. Some come to us without any experience in ALS, as you know, as much as we see and how rare it is. And then we have a lot that come through palliative care now. And so even some of our nurse practitioners have not had a lot of experience with it. And Judy authored the chapter on social work in ALS in the most recent Oxford textbook of palliative social work. So there's a lot of experience. Judy, would you add anything by introduction here before we get into the meat and bones?
And Joe, it sounds like your dog may be getting louder and louder.
Let me get my wife. Sorry. I think the mailman came.
Got it. I'm sure it's most
Go ahead, Judy.
Yeah. So one of the things that led to the development of this was this idea that with ALS, it doesn't present the same way with everybody. Different people can have a different set of symptoms, and only responding to the symptoms after they show up, sometimes that's too late to really be able to make all of the choices. So one of the things that this was initially developed to be is a training tool for newer staff to make sure that they were really hitting all of the ideas that needed to be discussed in their assessment and in their ongoing care. As we worked through it as a sort of a teaching tool, we realized it could be collaborative with the families because the families need education as well. So that's kind of what it went into it before. And as Joe said, he and I spent over 15 years working with ALS patients in the Chicagoland area. And when we first started out, we didn't know what we didn't know. And in spite of many efforts to develop that information and reach out to experts, we sometimes found ourselves in new territory, even after we've been doing this for a while. So this is designed to help people think ahead, to think about the what ifs. Some patients may never lose their ability to talk. Some patients may never lose their ability to breathe. But this is making sure that there's a plan in place if that happens and how they're going to respond. So we started with, it figures, now it's my dog.
Could you all hear me, or was it?
Yeah, we could hear you fine. It was just a little distracting. That's all. Yeah.
I've got the door closed here. My wife works upstairs, and she's.
Yeah, I have 2 dogs myself. We understand.
Okay, so we wanted to start with making sure that everybody has a clear understanding of who's on the team. Because with an ALS patient, they might have community resources, they might have clinic resources, they might have a hospice or palliative care team, and making sure that everybody on the team knows who everybody else is helps streamline communication and eliminate mixed messages. So that's where we start with making sure we know who's on the team. We also kind of do an assessment of what are the other resources for this family. ALS is a very resource intensive illness. And so upfront knowing what are the resources and where are we going to need to fill in the gaps is really important. Next, we talk about knowing the type of ALS that you have, because it presents differently and it progresses differently. And so educating people about, with this particular type of ALS, whether it's limb onset, bulbar onset, what would we anticipate in terms of some of the challenges that they might be dealing with. And then we start with a question of what's important, right? I had a patient once who said, as long as I can sit on the couch, watch baseball, and eat chocolate ice cream, I'm fine. Keep me around. But when I can't do that, I'm done. Okay, that's what the values are, right? So he didn't want a feeding tube. That was of no interest to him. So identifying for people what is the most important, what's the values that they want to prioritize, and that we want to make sure we as a team honor those values. And then the goals. What is it that they want to do to sustain their quality of life? What is going to be important to help them continue to do the things that they really need to do? So we want to, kind of do an assessment of life-sustaining interventions, how they feel about that. Where are they with their advanced directives, DNR? Where are they with estate planning, insurance, end-of-life arrangements? Just kind of making sure that we've assessed all of those in advance.
I'm sorry, it's jumping around on me. There we go. Okay.
So what is most important to those who assist you in your care is also important, right? Making sure we understand what are the values for the patient, what is important for them. Do they want to extend life as long as possible? Do they want to alleviate care partner burden? Are they interested in having not being a burden? What is it that's important to the patient? And also very much assessing what is it that is important for the people who are caring for this person. What is their understanding of what's going to be expected of them and what's important to them as this process continues. Okay.
I mean, there's of course the ultimate question: allowing natural death versus artificial life-sustaining measures. That, as we all know, that's can be forefront. So, go ahead, Judy. We start with our choices to make, and this is kind of progressive from less than to worse than.
Yeah. So we start with just really thinking about what are the things that are important to this person? What is it important for them to do? What do they want to be able to keep doing? We heard about a patient once who said he just wanted to be able to smoke a cigarette all by himself, right? Without any help. And he had an OT that helped him put together some equipment and stuff that would enable him to do that. Whatever your activities, interests, priorities are, we don't judge. We just want to make sure that you're going to be able to, we're going to maximize your ability to do that. And in order to do that, of course, we have to know what it is. Okay. And then the next one.
I'm trying here. Sometimes, see, it catches up with me. Sorry. My internet is really good too.
Okay. And then mobility, thinking ahead about what are going to be the resources needed, adaptations to the house, etc. And this is really important because what we found as hospice providers is that once people enroll in hospice care, they lose access to the Medicare benefits that would provide some of this equipment. So making sure that those conversations happen really upstream from the hospice referral is very important, to make sure that people maximize their access to equipment. Communication. What if you lose your ability to communicate? Are you comfortable with technology? Do you want to do voice banking? Learning how to use something like a Dynavox is intensive and is much easier to learn before you need it, right? So, but is that an effort people want to make? So just kind of really thinking through what are the options before you need them, so that when you need them, if you need them, you're ready to go. And some people don't really want to invest the effort into something that they may not need, and that's understandable, but at least the conversation is happening. I think the biggest goal here is really just to kind of limit the number of surprises, right, that people have to manage as their disease progresses. Okay.
Sorry. Oh.
No, we were there. Mobility.
There we go. ADLs.
Yeah. So assistance with ADLs, really thinking through what are the resources going to be like and available as people's needs increase. What are the financial resources, the community resources, the capacity of the caregivers in the home, really thinking through what that's going to need. And again, like, for example, perhaps a Hoyer lift might be needed, and you'd want to make sure you put that in place with other equipment that Medicare doesn't cover after people come on hospice. Okay, and then memory, mood, and cognition. So as we know, not all most ALS patients really do retain their intellectual and cognitive capacities, but not all do. And so thinking ahead with people about how would you want to manage that, letting them know that there could be changes in memory, cognitions, and sort of making it a plan for how they would want to address that, and what would be their family's approach to that and managing that, because it can be really hard for people when they lose kind of the ability to communicate even intellectually with their loved one. I think now we're on feeding, right? So this is the what if
Sorry. Okay, swallowing, that's next.
Yeah. So I see a question. It's okay. I'll just go ahead and answer that. Is it targeted to provide information for providers? And when we were developing it, we did initially develop it as a teaching tool. It's very rudimentary in terms of what providers need, but it provides a framework for providers to give you a sense of where you need to kind of go a little deeper. So it can be used as an educational tool for providers to use in conjunction with the patients. And yeah, just whatever is going to be the most effective. But we did initially develop it as a training tool, and then realized it had a lot of value to use in collaboration with the patients. So again, with swallowing, thinking ahead about what if it becomes difficult to swallow? And, you know, some of these things really came out of our own experiences. You know, I had a patient who woke up one day and she couldn't swallow, just like that. You know, it just happened. And, you know, she was looking at that point, you know, days to weeks without being able to swallow food or water without any interventions. And yeah, so that's a conversation that that really should have happened much sooner, but in her case, the symptom arose so quickly and so suddenly that I think nobody on the team was really prepared for it. So we want to make sure that we talk about all of these things before we need to. And as Joe said about microdosing, you can't necessarily have all of these conversations all at once. This is a lot to go through with any patient, but even in terms of your own perspectives as providers, like using this as a tool to even ask yourself, do I think I know what my patient would want when it comes to this? Or I check in with them. Are my understandings correct? Is this something that we've talked about or not? Is this an area that needs more exploration? So it can be really helpful for providers, just even as a sort of a checkbox to make sure we're covering all of our bases. So then again, breathing. What is their opinion about intervention there, for example, with a BiPAP, which can really starts out as a comfort measure and can become life-sustaining treatment. So are they interested in extended survival with artificial respiration? What are going to be the decisions they're going to want to make when breathing becomes more and more difficult, and how comfortable are they with something that starts as a comfort measure potentially becoming supportive treatment over time?
I'll say on these, and especially when you get into these areas here, I mean, I realize that the patients and families have heard it at the clinics and from their neurologists and whoever they've accessed before they go to palliative or hospice, and well, they'll say, "Well, that's not a problem for us yet," and so in our world, it's a lot about negotiation and how careful we are, and yet not neglect to frame it in the concept of let's talk about it now, just in anticipating what it is, and so
Yeah.
a lot of times it's they've heard it before, but by the time we get to it, it's starting to become reality for them.
And Amy commented in the chat, from my experience as a spouse, caregiver, and now mentoring others, swallowing is its own standalone issue. And yes, it absolutely needs very in-depth attention. And I think the idea is making sure that that attention happens and begins to happen very early in the disease process, so people can anticipate.
I'm sorry. What I meant was coughing.
Oh, coughing.
Sorry. Yeah.
Yeah. Oh, yeah, absolutely.
Coughing.
Coughing is another issue, which, yeah, might be something that we consider putting in as a separate item here. Kind of how to manage that and what to expect. Okay, are we here, Joe? At number 8?
Yes.
Okay.
Mm-hmm.
Yeah. So then, emergency plan. I mean, everybody should have one, right? We should all have an emergency plan, but with ALS, it's more complicated. It's much more complex. And so having a disease-specific plan for what if the power goes out? What if there's a flood? What if we need to evacuate? What is that going to look like? And hoping that, the resources are there, and understanding, I think we have to acknowledge that for a lot of people, this could be a very severe issue that may not really even have answers. But to the extent that we can, helping people think through what would that evacuation plan look like, or that emergency plan if they needed to make one, or when they make one. Okay.
We've even struggled within some of our clinical management and others in our company, recognizing the subset that ALS is, the uniqueness of this disease, that it's just different and has different challenges than many of the hospice diagnoses that we deal with. And so even though it is a smaller percentage of what we do, each case consumes a significant amount of time and resources, personnel, equipment, and everything. Yeah. And so that's kind of where we have set this disease apart. Judy and I have given all this special attention to this because nothing else has the kind of demands that this disease has.
Okay, and after the emergency plan, we have
I'm trying. I thought if I went really slow, it worked better. Okay.
so physical and emotional exhaustion. And I would say that almost without exception, the ALS patients I've worked with have gotten to a point where they've said, I just can't do this anymore. Like, this is just too hard. And so, sort of working with people to anticipate what would your wishes be? What would your options be? It's different in different states across the country. It's different, um, you know, if people are BiPAP dependent, do they want to discontinue that BiPAP when they're just tired of doing this? And so I think that the physical and emotional exhaustion is something that it's a hard conversation to have, but what would you want if that time comes? Again, I had a patient who was very specific in his wish for education. And when I talked to him about the possibility of like a sudden death event, because that's much more likely with ALS patients than with other diagnoses where you don't see it coming, he wanted to take control. He didn't want his wife to wake up one morning and find that he was gone. And he wanted his kids to be in the room. So he made that decision to discontinue his BiPAP use so that he could be in control of that end of life event. Without that education, he wouldn't have known how to make sure that those values that he had, which were really to take care of his family, right, to allow his children from out of town to be present with him, to ensure that his wife wasn't alone when he passed. That's what enabled that to happen. So that's our guide. And yeah, any discussion, questions, comments? We'd love to hear. Okay, so Farah says, would love to have a space there for physical or emotional exhaustion of the caregiver to normalize and make space for that. I think that's a really great idea. Absolutely. How the caregivers function through this is important. And I think we've touched on it at different points along the guide. But yes, absolutely, there's room for that. Yes, an entire guide could be made for caregivers. And this is really like a 30,000 foot view of the disease. It's not in any way, any one of these topics could be a book, right? Any one of these 9 points could be a book all by itself. As well as, some other items that were not included here. But it's a starting point. And some people will know exactly what they want to say about any one of these given points. Some people will use it as a starting point. Some people will say, I'm not talking about that. But at least we're giving people the option to think ahead and to get more in depth if they need and want to. And find more resources. Your ALS guide has a link to this in that website. There's thousands and thousands of resources there, and this guide, I think, is meant to identify for people, where do they want to go deeper? Where do they want to get more information? What areas do they want to learn more about? And what are their wishes and values that they are aware of in the moment?
This is great. Thank you so much for your work and for sharing it with us. I just to make sure I understand, it sounds like you're generally going through this guide with people who have recently transitioned to hospice. Is that right?
Or so it can be used at any
upstream?
point. It can be used at any point. So, and ideally, we would like these conversations to start before hospice because of those kind of Medicare specific guideline things that come up. And we try to introduce this as early as possible in the palliative care stream, so that by the time we come to hospice, most of these conversations have been had and addressed. That's really the goal.
Great. So you guys are using it more in your palliative care program?
We're using it. Not all of our patients come to us through our palliative care program. So if it obviously really does get used in the hospice program as well, but our emphasis really is on how to use this guide as upstream as possible.
They're using them in the clinics here in the Chicago area. We've kept them stocked with them here. I think there's 5 ALS clinics. Now, we have referrals from Les Turner too, and have been involved with them and have given them some guides. I'm not as close to how they're using it, but they do use them in the clinics here with our relationship with them.
And I think the earlier, the better. So Christy asked in the chat, have you seen the components of this guide work differently depending on payer source or insurance type? I can see how values and insurance may not always align. Yeah, absolutely. And that's, one of the really things that we have to work with is that difference between people who are on hospice and have access to Medicare benefits that people, on palliative and have access to Medicare benefits that people on hospice don't. That's a really important real life on the ground kind of consideration that we have to keep in mind. I think that insurance doesn't always help, right? Sometimes insurance won't approve something until it's needed. For example, the Dynavox, right? What if someone wants to practice and learn how to use it? They're losing their voice, but they haven't yet. And they want to, while they still have a little bit more strength, they want to do the hard work of learning. And what if the insurance won't pay for it until they need it, right? So there definitely are issues with insurance benefits and making room for that and accessing lending closets to where we can, finding other resources. That's one of the things that we really, try to do for people if insurance isn't going to provide for them what they want and what's important to them. Okay. Suggestion to add a bullet point about equipment and home modifications. Yeah, that's a good idea. Thank you. Let's see. So then Dan said, how great is the need to get this information out to physicians? In other words, what are the chances that a new ALS patient in the U.S. will run into a physician who is unfamiliar with ALS symptoms and approaches to ALS care? I am going to open that one up for discussion. What are the chances that an ALS patient in the U.S. will find themselves working with a physician who is unfamiliar with the disease?
Likely. Yeah, it could be a primary care physician, it could be a palliative care physician, but I think it's reasonably likely.
It's the average is what 18 months from first symptom to diagnosis, or is it longer? It might
about
be
12 to 18 months.
Yeah, and that is because there is so little expertise in ALS in the general medical community. But once you get to a clinic, yes, you're going to be working with people who understand, but it's getting there, getting the diagnosis. And that process of getting the accurate diagnosis, of course, leads to many misdiagnoses and treatments that don't work, and people can develop a sense of cynicism about the whole process, right? Like, yeah, you told me it was this, and then you told me it was that, and now you're telling me it's something else, and why should I believe you that it's ALS?
Maureen, I think your hand was up, and then Amy.
Yeah.
Thanks for sharing this. And I think, Joe, when you gave it to me at the conference last year, it was really exciting to see. It's beautiful in print as well. I'm a palliative care physician in an ALS clinic, and don't have a social worker or a chaplain in my clinic if you guys ever want to come over and join me. But it's already a struggle, as I'm sure to get people to complete advanced directives and fill out forms. And we give a handout of a lot of information to them. There's also a lot of existing resources online too, right? Like there's Les Turner has stuff, and your ALS guide, which I know this is on. And so two questions, right? One is, how have you all in practicality of actually using this, right? How have you guys seen it be incorporated into the landscape of already existing resources, which I think this is unique, having gone through those things and seen them. I know this is unique in terms of the way, like what it's getting at. But I'm wondering how you've seen patients and care partners actually like actuate these. And then these are not, correct me if I'm wrong, but these are not like legal advance directives, right? You still have to do an advance directive separately, right? So then, you know how advance directives take a long time to fill and they cover a lot of this stuff. And I see this as kind of like a workbook to that, but because it's nicely specific to ALS compared to like the 5 wishes, which is not specific to ALS, but also very similarly workbook-ish. So
Yeah, it's
I'm
kind of
curious, like, as I think about incorporating this in my practice and then how to minimize like how much work patients and families have to do, how have you guys found it being used?
So it's really different for different people in terms of how, for our providers, for our clinicians, how they understand the patients. We don't just sort of have a one size fits all approach, right? This is a resource that we have available to use, but it's not necessarily going to be appropriate for everybody. And not all parts of it are going to be appropriate for everybody. And these each one of these items is it's like having that advanced directive conversation over and over and over again, and it's exhausting. So I don't see it as a one shot. I really don't. I think it's something that we can start with, and I really encourage our providers to start with just, if you have thinking about your patient and thinking about these items, what do you understand about this patient's wishes, goals, status with any one of these items? Is this something that has been talked about? Do you understand what the patient's knowledge base is around this particular subject? Like, I think as a starting point with clinicians, it's an assessment tool. And then interacting with the patients to kind of take it a little further.
Amy, I mean, as far as formally using this guide, I mean, Judy and I have been out of the field, so we're not seeing the patients now, but it represents the kind of conversations we were having. And the challenge is we don't have the evidence of how it's being used. When we talk to those in our company, and so they come with their cases, and we start asking these questions of our staff, and they, in a lot of cases, have not. They're not asking these questions. You put this in their hand, and they come back the next time, and they may have they may have worked through it. It's just hard to impress upon the clinician that if you wait, you're going to be the horse is going to be behind the cart. I mean.
And I think sometimes too, like when the clinicians have a familiarity with this guide, it enables you to look for those openings, right? Those little cracks in the door where people might be kind of ready to talk about something. And if you are alert for it and looking for it and listening for it, you'll be able to kind of say, yeah, tell me more about that, right? When that first comes up. So I think it can be, yeah, it's by no means is it a one shot. Okay, Amy.
A couple of things under resources. One thing that's kind of happened since I was a caregiver to my husband is there are a lot of mentoring opportunities opening up for particularly caregivers, but also the pals to talk to somebody in that situation. And I think that's, I wish I'd had that. And I'm a mentor now. And I find that to be really valued by the people I work with. So I would add that to resources.
Yeah, that's great. And I love the idea of mentoring for caregivers. I think that is so powerful.
And then the other thing is, as I was reading it, it seemed like the identify your values page came a little prematurely, because some of the decisions or decisions basically that were being addressed probably weren't at that point, might not have been well understood by the people making the decisions. One example is a feeding tube.
Mm-hmm.
A lot of people will say no to a feeding tube, and then and I get this from reading the posts on Facebook and what have you, and talking to people. They'll say no to a feeding tube, and then they decide maybe they want a feeding tube, but they're too far along to get the surgery. So I would suggest that these other discussions come before the page where people are starting to make their decisions.
Yeah, absolutely. Having that discussion about swallowing in the feeding tube early, was that problem that you described was one of the drivers, I think, in developing this, was, making sure that conversation had been had and is happening when it needs to. But thank you. That's a really good point. Kara, hi.
Thank you. Do you mind if I share my screen briefly?
Yeah.
I was just trying to put this all together for if there's any other clinicians out there who are like, okay, there's a lot of different resources. I'm trying to keep them straight. This is one of the things I do, but not the only thing I do, and it's all a lot. I thought I might just summarize how I'm thinking about this, because we had a recent conversation from the Waiting Room Revolution team talking about this other ALS symptom roadmap. And I was just trying to compare this to what we saw today, and then other resources through Les Turner and your ALS guide. So pulling this up from the Waiting Room Revolution, we heard about this on a prior monthly conference call. This is a very much more brief 3-page informational sheet about the illness, summarizing common, aspects of the illness. And so very, very different from what we're hearing about today. I was trying to remind myself, wait, how similar or different is this? Okay, very, very different. Much more brief, much more about educating people about the illness so that they can be prepared for what's to come. And then on Les Turner, they have a lot of different information and educational resources there too about ALS and breathing, participation in clinical research, nutrition. They also have this My Decision tool that helps people with specific decisions, around participating in clinical research, genetic counseling and testing, breathing support, nutrition support. So decision tools. So that's helpful. And all of that is quite different from what we heard about today. Sorry. Which is your values assessment guide. I know we just looked at it. Sorry, I thought I had it pulled up a second ago, and now I'm struggling to find it. But anyway, we could download it again. Oh, it's right back here. Which is, as you guys just saw, 21-page, very detailed opportunity for people to express a lot of their preferences, values and preferences. And so in my mind, this could be appropriate to use directly to pull this up and directly go through it with that. In my practice, it seems to be a smaller percentage of patients who really just love this idea of planning for the future, advanced care planning. There's some people who really want to express their wishes and want to detail them out on a piece of paper, and that's very helpful to their thought process. But there's also a lot of people in my practice who I think get easily overwhelmed with advanced care planning. And for that larger number, I might use this, like what you're describing, Joe and Judy, to kind of go through it on the clinician side and say, have I addressed these issues with people? These are things that I could bring in to different visits and conversations over time. It's going to be less overwhelming to most people in that way. And I think that that's how I how I typically practice. So I don't know if that was redundant or helpful to anybody, but I was just like in my own head trying to figure out what are all these different resources and
I was
how
doing the
are they
same
similar or
thing.
different?
Yeah, I was doing the exact same thing. I have all the tabs open that you just opened up, Cara. And Susan, in the Cara, can you also just do one more screen share, because Susan just shared a really nice end of life like companion to her advanced directives that she uses. Susan, I'm speaking for you, but I just pulled those up and opened them up, and they're really nice too. Do you mind?
Sure. Hang on a second. It downloaded somewhere. Now I have to find it. Here it is.
But Susan, do you, because I
sure.
think it's especially when I do advanced directives with patients, I do a lot of like, well, this is really different than other diseases, and the complexity is that your heart is still fine and your lungs are fine, and it's a different conversation than if you didn't have these diseases. So
yeah, it really was made just to
Interesting.
specifically go with an advanced directive and those questions that it asks in a regular advanced directive, and then what does that mean if I have ALS? So it kind of walks through the bigger questions.
Yeah.
This is specific to Oregon. That's where we're from. So there is some death with dignity verbiage in there that might not pertain. But, we can get you copies that you can edit if anyone truly wants it.
I have a question, Susan, because I know Sam Miser was working. He's at Hennepin Health, and he's a director of their ALS clinic there. And they published on an advanced directive that this is like a supplement, I know, but they created a specific ALS advanced directive that they studied. It's only in an abstract form online that I can see, but I'm sure, I don't know if Sam's working on a full manuscript. But one question I had was, when I talked to him about using that in our clinic, he said it has to be, like state approved, right? Is this something that is is this also not a legal document? Like this is just like similar thing.
Yeah, okay. It's not an advanced directive. We recommend to our families that they fill out the advanced directive and then attach this to it so that it's uploaded with it. But no, it is not a legal document. But it's a good conversation starter, and our families that have used it have very much, they tell me they're thankful for it because it really helps them decide what decisions to make on that advanced directive, knowing what ALS means. So, but no, it is not a legal document. It would just be a supplement to that would get uploaded with it.
My experience has been that, patients, family members, and clinicians use information about values and preferences that's documented in an electronic health record all the time, and that it's perhaps ideal if things are on a legal advanced directive, but there's, in most cases, a lot of information about people's values and priorities aren't on a legal document, but still can be helpful to guide care.
So that's great. Is this a file that we can add to our ALS working group? Like, our file on the Connect Trade.
I was just emailing all these to Gail, suggesting exactly that. Can we circulate these and post them on TradeWing? Yeah.
Is that okay with you, Susan? Or we can share? Okay. And Judy and Joe, is that okay for us as well to post? Like, there's no pay walls or anything.
No.
Thank you. Just making sure.
Please do, Amarine. Yeah, I mean, what you all are saying is you're right on. This was never meant to. It's only a supplement to those materials. That's why we feel like it's best used in the hands of a moderately well-informed clinician working with someone, because not only can those decisions be based on their values, but it still leaves lots of information and questions that need to be addressed that are supplied by the wonderful wealth of resources that are out there at various levels.
Makes sense. I feel like, maybe 2+ years into this working group and like 8+ years into caring for people with ALS, I'm finally starting to get a sense of the landscape of all these materials. So thank you for helping my slow learning process. It was great. So if you don't mind me torturing you just once more, I'm going to pop this little note into the chat for those who joined late. But again, if anyone is interested in the mentorship panel about working with people with ALS, that's on November 19th through AHPM Neuropalliative Care SIG. If anyone's interested in entering information about their program into our directory, we'd love to have it. And if anyone would like to participate in the sialorrhea management study, that would be great. So I'm going to drop information on all that back in the chat one more time. Feel free to reach out. And I hope everyone has a wonderful Thanksgiving, and we'll see you all in December.